So during next 45 minutes, I'll be covering CVD risk assessment, obesity and its complication, and the therapeutic options which are available. I'll be asking you questions, so pay attention, people on phones and all, I'll be pointing them out. If I ask you one simple thing, and it's time to reflect. If we don't die of an accident, poisoning, self-harm, or don't develop cancer, it's going to be CVD which is going to kill us. Statistically, the chances are high. I'm not talking about people who are very young in here. I've reached the 6th decade of my life, so probably when I think about it, this is something which is preventable. And I'm sharing title of a book, Atul, my namesake, who's 100 times more rich than me. And I don't know if any one of you have read this book. It's deep, it's nice, must read. Along with Paul Kalhan's book on When Breath Becomes Air. Globally, we know 1 in 10 people aged 30 to 70 die from cardiovascular disease. CVD remains a preventable reason of premature morbidity as well as mortality. My sessions are mostly clinical scenario based. I'll ask you to do the hard work here. You're sitting in a clinic. You see a man of the same age as I am, has background history of type 2 diabetes, which was diagnosed around 10 years ago. BMI is 32, slightly more than mine. So blood pressure 148/86. I've given you the cholesterol readings and triglycerides. Have this scenario in mind and give me answers, or at least think about it. What do you think was the CVD risk for this gentleman? You can write it down. You'll get the answers in next few slides. A man, 53-year-old, and what should we do to mitigate these risks? Right? Couple of slides on the theoretical part of it, and this is my favorite slide. For the reason I know atherosclerosis is a multifactorial process. It starts quite young age. In fact, in teenage, there can be atherosclerotic plaques in people with familial hypercholesterolemia. This risk is in a continuum, and we need to be mindful of a lifetime risk approach. Higher the baseline risk, earlier intervention being beneficial. If you break down everything related to CVD, it's atherosclerosis. So, for example, if I get a medication which can keep your LDL at 0.1 for as long as possible, probably from age of 1 or 2, you live far more longer if everything else is taken in account. I didn't ask them to do this celebration, but yeah, that's fine. There is a beautiful concept which is coming in. Similar to PEC years, we need to calculate our LDL cholesterol PEC years also. How long LDL has been high and how high it is. So if you keep it in mind, it will be much easier to deal with CVD. Very soon I'll be starting to, dance and now CV risk assessment, when to screen, when not to screen. I think we can start to So we need to not screen people who are young with no CVD risk. We don't need to screen people who are young in age or over 80, because over 80 the risk is bound to be there. The strongest risk for CVD remains age, right? So it's inevitable to get atherosclerosis once you are older. We don't need to screen people with type 1 diabetes or type 2 DM with end organ damage, because they are high risk to begin with, right? We don't need to screen people with kidney disease. Most of the data which we have derived for the CVD risk assessment comes in from the Framingham study. It's a beautiful prospective study which was started in 1948, still churning out papers. And it was only in 1960s in which Framingham study provided us with the data about smoking being a risk for CVD. Prior to it, we didn't know. There are multiple risk engines which are used. In UK, we use QRisk3. The slide here mentions about QRisk2, but that's more in primary care. But a QRisk3 engine is available online also. And it's quite surreal if you try to do your own CVD risk assessment using this risk engine. It takes into account your ethnicity, your socioeconomic status, multiple other factors. There are multiple risk engines, and I think in Asian population also, in most of the countries we practice, we should adapt one of this CVD risk assessment tool, which we should propagate and spread to the general population. People should be doing these engines, using it online, doing their own assessment. The only problem is that there are CVD risk modifiers. So if you see somebody with autoimmune condition, SLE, rheumatoid arthritis, Sjogren, they are at high risk to begin with. People with CKD I mentioned about, being from lower socioeconomic strata itself is a risk. Having family history, especially familial hypercholesterolemia or similar disorder, your CVD risk is high. And I mentioned about these risk engines. Most of them give us a 10-year risk estimation. More importantly, we know there is a lifetime risk assessment which needs to be carried out. Most of these risk assessment engines or tools underestimate the risk if it's a female or somebody who's young, relatively young. So anyone in your clinic, if you want to do a CVD risk assessment, one alternative, use one of these validated risk assessment engines, or try to assess a lifetime risk. And this is a paper we wrote more than a decade ago in which we advocated a lifetime rather than a 10-year risk assessment, which tries to ration the use of statins, nothing more. Multiple biomarkers. I'm an endocrinologist. I'll not talk more about apolipoproteins. There is more and more stress or emphasis by the lipidologists that we should be measuring apolipoprotein B, which is far more accurate than LDL or non-HDL measurement. We've got multiple lipoproteins. Every lipoprotein has a single apolipoprotein B. The higher the number, higher the risk, and it's more accurate for CVD assessment. Hopefully in next few years with more development, we'll be measuring apolipoprotein Bs. High sensitivity CRP can be measured. There is something known as LP little a. And in people with early cardiovascular disease which is running in the family, it's important to measure it at least once in lifetime. Lipoprotein little a. CA scoring and all, I'm not going to go into the details of it again. It's more a topic for cardiologists and availability of resources. And I love this slide for the simplicity of it. I practice in an area in which I can do the genetics for familial hypercholesterolemia, for familial chylomicronemia syndromes. There is no dearth of resources in place where I practice. But there are areas in which, despite the prevalence of diabetes being high, resources are limited. So if you see somebody with, type 2 diabetes and you're thinking about life-saving measures, simplest thing you can do, start metformin, a statin, ACE or ARB. You've done your job. You have already increased the lifespan of this person by using medication which will improve glycemic control, lower the non-HDL cholesterol, and control the blood pressure. If you've got more resources, you can do more things. So often in my clinics, people come in and ask me, I'm not going to use statin. Statin kill, statin lead to dementia, statin lead to this. I get aches and pains with statin. Statin has destroyed my liver. So the evidence of lowering LDL cholesterol is unequivocal. It's driven by multiple RCTs and meta-analysis. Everything is cause and effect, and it's cumulative. And there is a whole lobby which disagrees with us. I think statins have been instrumental in lowering the CVD risk over a period of time. I did ask you about CVD risk assessment to begin with. I'm giving you a very simple slide, which is from the EAS and ESC, European Society of Cardiology 2019 guidelines. And make a mental note of it. You've got somebody with diabetes in your clinic who has end organ damage. And end organ damage can be retinopathy, nephropathy, neuropathy, anything. They are, to begin with, high risk for CVD, irrespective, period. In addition, you can focus on FH also, familial hypercholesterolemia. At least in the part I practice in, is common in 1 in 300 people. I keep on reading people dying early in life because of a cardiovascular event, but we don't bother to check their non-HDL cholesterols or LP little a's, or think about the cumulative burden of these apolipoprotein Bs, right? So this simple slide I often use in my clinical practice because it risk stratifies CVD based on some of the things which we have discussed so far. Earlier this afternoon, I did ask questions. I didn't give answers. What should be our non-HDL or LDL cholesterol targets? In high risk or very high risk patient, the target should be less than 1.4. If you convert it into milligram, it's under 54. And high risk is under 70. As I said, I'm not making it up. This is all evidence-based. This is from ES and ESC 2019 guidelines. If people are having recurrent CV events, the target is even lower. It's under 1 millimole per liter, which is around 35 to 40 milligram per deciliter. So think about it. Often I get WhatsApp messages from my relatives or friends from India saying, oh, my cholesterol is perfect. But when you read the LDL values for them, it may be 80 or 90. The perfect is because the lab gives you a range kind of, which is not individually applicable, right? So these are the targets which you need to follow. Coming back, again, we are reaching late evening stage at the moment. I need to keep you awake. Read the scenario, try to find answers, and tell me importance of lowering triglycerides. So you see the same individual I mentioned, 53-year-old, has type 2 for 10 years. You are focusing on LDL cholesterol, which is 116 or 3. What should be your target now? I've just covered it. Is it high risk? Yep. So high risk target is brilliant. What about the triglycerides? We have covered the LDL cholesterol. Often in clinical practice, I'm asked this question, oh doc, my triglycerides are high, what should I do? What is the first thing which comes to your mind?
After correcting LDL, we had to focus on.
Exactly. Thank you, Ram. Thank you. So when I'm looking at the triglycerides, the only thought which comes to my mind is, what is triglyceride? 3 fatty acid linked with a glycerol, part of our chylomicrons, which carry the extra nutrient from intestine to the liver, and the liver is churning out some triglycerides. So they are part of lipoproteins which are lipid rich. So My first question is, number one, how severe it is. Mild to moderate, severe is more than 10, or multiply it with, I've given the range here also. In UK we follow millimole per liter, but severe is more than 885, which is more than 10 millimole per liter, right? Now, second question, what is the reason for it? And the reason we categorize between mild, moderate, and severe is severe hypertriglyceridemia, higher risk of pancreatitis, right? CVD risk, we can talk about it. I can have a full house debate about importance of lowering trigs, how much we need to lower. Second question, what is the reason for it? If I've got somebody with high LDL cholesterol, I know I need to look for familial hypercholesterolemia or similar disorders, right? Chances of finding familial hypercholesterolemia is 1 in 300 to 1 in 500, depending on the population you work in. For the triglyceride monogenic part, it's extremely rare. FCS, or familial chylomicronemia syndrome, is present in, let's say, 1 in 400,000. But there is something known as polygenic or multifactorial chylomicronemia syndrome, which is far more common, 1 in 400. It's smaller mutations combining together. You'll get everything in a PDF file. At the, in a small print, there are some genes which I've mentioned. Normally for familial hypercholesterolemia, I carry out genetic analysis, but for high triglyceride, I only screen for FCS if the triglycerides are over 10 and there are no secondary factors. FCS presents very early in life. By 10 or 20, it's through autosomal recessive mutation. It's very aggressive. People get recurrent acute pancreatitis episodes. Now, one thing which I want to ask you, which has therapeutic relevance, and if you have lowered the LDL using statin, are you going to use fibrate, omega-3 fatty acid? Do they really benefit? Yes or no? Does lowering triglyceride help in reducing CVD risk? This is my question too. Very simple. Do you think lowering triglyceride lowers the CVD risk? Yes or no?
Yes.
Yes. Okay. Anyone says no? Most of the evidence for lowering triglyceride and improvement in CVD risk comes in from observational studies and Mendelian randomization studies. But strangely enough, if we have tried to lower the LDL, the triglycerides, using fibrates and omega-3 fatty acid, apart from one which I'll mention, icosapentaethyl, there is no CVD risk reduction. Strange. That's why what Dr. Ram mentioned about, that if you see a patient with diabetes, try to optimize the glycemic control, try to reduce the non-HDL cholesterol, and then if everything is constant, try to lower the triglyceride. Don't jump into lowering the trig to begin with. Apart from fenofibrate field study, which led to reduction of diabetic retinopathy, there is no evidence that there is CVD benefit. It's only recently now that icosapentaethyl, which is icosapentaenoic acid, which is showing some CVD benefit, but that's independent of triglyceride lowering. Vascepa is the brand name for it. So very interesting. For FCS, there is a medication which is, approved by EU, not by the FDA to my knowledge, because it messes up with platelets, volensorsen. So I had a patient with MCS now, the multifactorial chylomicronemia syndrome, genetically proven, very recently diagnosed. I wanted to use this medication for that gentleman. One, it's very expensive. Second, I need to monitor the platelets every week, kind of. So it was me who had developed cold feet on thinking, oh, I don't want to have platelets monitored every week for next 3 months. Volensorsen is a medication which is approved in EU for lowering of triglycerides. In FCS, nothing else. Don't try to do it in general practice for your secondary hypertriglyceridemia, which are far more common than FCS. Okay, so I've spent the first 20 minutes of my talk talking about how to calculate CVD risk. I've mentioned about how to monitor it, how to assess it, how to risk stratify, mentioned something about trigs, which is a topic on its own. Let's move on to obesity. What do you think? What does the house think? Is it a disease? Is it a single entity? What is the problem in here? How do we define obesity? It's a disease. It's a chronic disease. Do you think it's due to some kind of genetic mutations? What are the genetic mutations we know of at the moment? A very small proportion of obesity is because of genetic mutations, and that's usually which presents very early in life, childhood hyperphagia, hypothalamic disorders, right? So there are small proportion of people, young adults, who will present to pediatric endocrinologist or come to your clinic who can't stop eating because there is a pathway defect in hypothalamus. One myth in clinical practice is it's the thyroid which messes up with obesity, and I get lots of referrals and phone calls, it's my thyroid which is underactive. No. The role underactive thyroid gland plays in obesity is minuscule. Cushing's disease, yes, can lead to it, very aggressive, but there are other telltale signs which are very clear and prominent. So if you see an individual who is 30 to 40-year-old and obese, highly unlikely it's a genetic condition, you can check the thyroid function, correct it, that's an easy win. Cushing, highly unlikely, because more likely it's going to be pseudo-Cushing, which mimics it. In clinical practice, when we did an observational study, only 1 or 2% of people labeled as type 2 with other clinical signs had some element of hypercortisolism. So I don't routinely screen for these conditions in an obese individual. Okay, let's move on. What do you think leads to obesity? In the part of world where I practice, it's a disease of affluence, poverty. In the part of world we live in and doing a lecture, it's a disease of affluence, right? So in a nutshell, it's caloric surplus, because human beings have forgotten to eat based on their hunger reflex. We eat based on our appetite, go out, things will be available, and we'll be on a routine eating, but we've forgotten to be hungry to eat. And anyways, I'll not go into the details of it. When I started to practice, and I'll tell you there are 3 eras of diabetes management. Most of the evidence we follow at the moment comes in from UKPDS, which was a prospective trial for type 2, and DCCT for type 1, right? Early evidence. From 95 to 2010 odd, I call it an era of doom and gloom. Every single trial which we did, name the trial, Accord, Advance, Veterans trial, everything suggested if we lead to hypoglycemia, there is worse mortality. So after the initial euphoria of DCCT and UKPDS, every single trial, if you read between 95 to 2010, and then came a medication known as rosiglitazone, which we started with lots of enthusiasm and ended up with lots of heart failures. And in 2004, I'm quoting a paper here that life expectancy for people with diabetes was lower than general population by about 15 years. I think suboptimally controlled diabetes still holds the same kind of value. It adds on 10 years to your vascular age. Then come in from 2015 onward, what I call as a hope and optimism era. I remember coming to India a decade ago, and I was one of the speakers invited by AstraZeneca to launch dapagliflozin, and we didn't know much about this medication apart from its role in, some element of glucose loss through the urine. If I had gone to sleep in 2015 and woken up a few years down the line, I would have been surprised why SGLT2 are being used by my cardiologist and nephrologist friend in non-diabetes population, because in 2015 we didn't know about it. Another big thing which has happened in last few years has been incretin therapy. And you would have attended multiple sessions on how incretins work. And I think part of the reason why you get educated about SGLT2 and incretin more often than other thing is pharmaceutical bias. They've got the medication, they need to sell it, they need to tell the consumer what it means. So I'm talking about the journey of how incretins have evolved over a period of time. I remember using exenatide, which was leading to granular kind of formation at the site of injection. We were happy to use liraglutide once a day, and then came in dulaglutide and semaglutide once in a week kind of preparation. There came a time in 2021 when Western Europe and US ran out of Ozempics. The simple reason for that was that it was being used so much for cosmetic reasons in private sector. It was not available in National Health Service. NHS ran out of these molecules. So as the things stand, anti-obesity medications which are available in UK, and I'm only talking about anti-obesity, I'm not talking about diabetes. So people with increased BMI, plus minus comorbidities, without even having diabetes, we can use high dose of liraglutide, comes in under the name of Wegovy. We get, liraglutide is, semaglutide and tirzepatide Mounjaro. Wegovy is semaglutide, sorry. Wegovy is semaglutide. Liraglutide is Saxenda. I've not used it for a long time, so I'll not be mentioning about it. It's the tirzepatide or Mounjaro, which is showing promising results. Try to, read few of the names in here, and this is the slide I prepared around a fortnight ago. These are the anti-obesity medications which are in pipeline, which include oral non-peptide GLP-1 receptor agonist. There is a dual amylin and calcitonin receptor agonist coming up. Lots of waves being made by amylin agonist again, and the 3G molecule, retatrutide. So mark my word, watch this space. Management of diabetes is going to change over the next few years. I'll come to it. I'll try to sum it up. This is a single slide. You'll get a copy of it in your, there'll be a flash disk which will be given to you. On December 20th, 2024, Redefine 1 trial top results were announced, which mentioned that combination of cagrilintide and semaglutide. Cagrilintide is amylin agonist, showing promising results. If you look at the baseline body weight in here, 106.9, in people without diabetes, after 68 weeks, 22.7% average weight loss, mean weight loss. Jan 24th, which was 3 weeks ago, another top line result comes in for amycretin, amylin receptor agonist with GLP-1 receptor agonist. Phase 1B and 2A results, mean baseline weight here is 92.7 kg. Think about it. It's not, it's at least 10 kg lower than the previous trial results I've shown. 22% weight loss on 20 milligram dose at 36 weeks. So one of my students who did a MSc dissertation, Dr. Wael Sidrak, very bright boy from Egypt, he wrote a paper published in IGM, Indian Journal of Endocrine and Metabolism, published last year. We looked at how glycemic control gets altered by weight loss. If you're losing around 1 to 5%, zero is an error kind of, some weight loss, it improves your glycemic control. Weight loss between 10 to 15% has a disease modifying effect. Lose more than 20%, you may put diabetes in remission. Very interesting data. In my first session also, I did share with you the same kind of concept that we should not take diabetes as a single entity. If we've got an opportunity, we should focus on weight loss. How we do it is different. I know there is limitation of availability of medication at the moment. It's only Ribelsis which is effective, which is available in India at the moment. And I know of people who have smuggled it from other routes, from Dubai and other, to use injectables also. I know of some people who have approached me about, using GLP-1 receptor agonists. As the things stand, one of my third-year medical student is doing a project on 150 patients on tirzepatide, which we started last year. Hopefully by next couple of months, we'll be presenting our data in a national meeting. Very busy slide again. I'm not going to go and read every single thing. If we think about obesity challenges, one, huge impact of lifestyle factors. We still don't know about the genetics of it. There are some kind of hypothalamic disorders which affect people at a younger age group, lead to hyperphagia. There is a medication available for it known as setmelanotide, which is approved by the NICE for use in people with some kind of melanocortin 4 receptor defects. Setmelanotide, approved by NICE, but genetically confirmed hypothalamic obesity, right? In Western Europe, in UK, we are using GLP analogs. I've stopped saying only GLP-1 receptor agonist. I'm using incretin word more often because we are getting dual incretins and a triple agonist is in pipeline. The problem we are facing at the moment is, moment you stop the medication, the weight gain and the glycemic control may deteriorate again. There are problems with side effect of these medication also. There is something known as Ozempic phase. They lose muscle mass. And there are phase 2 trials going on in which they are trying androgen receptor agonist for it, or myostatin agonist, phase 2 at the moment, in which they are giving a GLP-1 analog along with a myostatin agonist or androgen receptor agonist. So too early to comment on it, but weight loss, muscle loss, and side effects, cholelithasis. Pancreatitis is not as, the signal for pancreatitis is very weak. Medullary thyroid cancer seen mostly in animal models, not in human studies. So the challenges we face are multifold. I'll spend 2 or 3 minutes here to share a personal story about a patient who I looked after. I saw him from 2005 onward. His name was Mr. RP. He was quite a tall, very gentle kind of individual, used to attend the clinic, sitting in a corner, not uttering a word. When I put the story together kind of, he was diagnosed to have diabetes in 1990 when we had sulfonylurea and metformin and insulin available. In 2002, he developed peripheral neuropathy, which went on to develop foot ulcer, osteomyelitis, Charcot's foot in 2012. Mr. RP developed a cerebellar infarct in 2016, age mid-50s or late 50s, and after 6 months of rehabilitation died. It touched me because I had looked after him for 10 years from 2005 onward. I thought about him and reflected on it. If there was something I could have done, and you can only come to know about these things when you have practiced enough, because we meet people at a single point of their life. We don't meet at, we can interact multiple points, but when we meet them, it's a single point. If something could have been done for Mr. RP, it would have been in the green zone. Once he moves into the complication zone, you are putting in more effort, more resources, outcome you get is less. And part of the reason you are part of this DASG group, Diabetes Asian Study Group, is to promote diabetes-related education, improve research, collaborate together. You are advocate for something which works, right? You'll not be able to deal with more than one patient at a time or maybe 50 in one day and multiply it. Your role is about spreading awareness which is factual, evidence-based, not based on WhatsApp groups. And there is a university also, WhatsApp University I've heard, which advocates cure of type 1 without insulin by doing yoga, right? So the key messages: CVD risk are multifactorial and often progressive. You need to identify them, individually mitigate them. In diabetes, please shun the glucocentric approach. If you've got somebody with diabetes, focus on giving a statin, metformin, ACE, ARB as the circumstances are. If you ask me about it, can I predict future? Nope. But if I have a crystal ball, I can tell you that very soon these anti-obesity medication, if they become less expensive, more freely available, can change the landscape. If I can bottle in lifestyle measures and try to sell them and patients follow it, that's probably a better medication than anything else. This is me, who was a lazy guy at age of 39. Age 51, I completed my first sprint triathlon. That's not a long distance. Swimming open water for 750 meters, cycling for 20K, and then running for 5K. I'm planning to continue to do it till I'm 55 or 60. First goal is reaching 55, not very far. You need to be advocating the same thing, if you are practice what you preach. So I'm sharing a slide with Q-risk scoring, how to carry it. It's online, it's freely available, you can use it, test in your own self. I'll use the next 5 minutes or so to test if you've imbibed what I was going through and if you've retained things also, right? CVD risk for this woman: 48, type 2, has rheumatoid arthritis, which is autoimmune. High risk, very high risk, what is your answer?
High risk.
Okay, high or very high, it's fine. Guidelines are for guidance, they don't bind us, right? So high or very high, that's fine. So what will be the most appropriate step to reduce our CVD risk now? Forget about diabetes now. I'm talking about which out of these 5 will be the most useful step to reduce her risk. We discussed. Statins. You can add in Bempi if it's not being controlled and use the celebrated placebo ezetimibe if wish to. Correct, statin. Very simple message. I'm not a complex person. I want to give you something which is very simple here. Second question. 35 on metformin, and atorvastatin. Cholesterol levels have been controlled now. They are, in the safe risk, right? If he was high risk with type 2 and had retinopathy or something, you have lowered it enough, right? Triglycerides are high. HbA1c is 50, right? So please remember this scenario and try to answer the next question. All right, okay, I'm not committing to fenofibrate. Maybe I'll not ask. His HbA1c is 50, right? BMI is 28. So which medication will be helpful to reduce his CVD risk? I've optimized the glycemic control. Icosapentaethyl. I'm a bit cautious about interpreting the data of icosapentaethyl because it comes in from 2 trials. One was JELIS trial in 2009, which was carried out in Japanese population. There was another reduced trial, results came in 2018 or 19. It needs to be analyzed in further detail, but icosapentaethyl as the thing stand is approved by NICE for use in this group of patients, right? Correct. Third question, so 42, type 2, reviewed on your clinic visit, HbA1c of 8.7%. You start thinking about giving him a GLP-1 analog, right? Patient can afford it, you want to change the outcome. Which of these is a known side effect of semaglutide or a liraglutide? C. Cholelithiasis. Pancreatitis signal was very weak, right? Medullary thyroid cancer in animal models, not in human studies so far. 17-year-old admitted to emergency with acute pancreatitis, recurrent episodes of abdominal pain. I'm taking you towards a diagnosis of FCS, familial chylomicronemia syndrome, very rare, 1 in 400,000. Trigs, very high. You keep him nil by mouth. Om was discussing a case earlier in which he mentioned about, choice between insulin or anything. High trigs need insulin, need starvation. You need to give rest to your liver and gut. Okay, so which medication out of the following, if you are paying attention, you will be able to answer it. Volensorcin. Last question. 15-year-old boy referred from pediatric endocrinology clinic. This is the typical way they present: morbid obesity, delayed growth, hypogonadism, delayed puberty and growth, everything. Endocrine hormone assays a bit deranged. MRI PET rules out any structural lesion, and you do the testing for him. He's got POMC, pro-opiomelanocortin gene mutation. Which out of these is approved treatment for such patients? Setmelanotide. Well done. Thank you.